Hey guys, we're from Sullivan Physical Therapy. We're located in North Austin around the Lakeline exit. So I've been at Sullivan Physical Therapy for almost 2 years now and worked in orthopedics before, and Lauren's been there for about the same time. So we want to start off the presentation talking about overarching questions, that a lot of people probably have in mind, but they're not sure exactly what to ask. So one of the things is, we get this a lot, is how many people are actually aware of that pelvic floor therapy exists. From my experience, it seems that it's probably 5% if I gave it a percentage. Most people just think of PT being in sports medicine and working with orthopedics, low back pain, the general kind of pains, aches and pains. So yeah, it is actually all over the nation. Austin is one of the places that we're very fortunate to have as being very specialized in pelvic floor. Another question that we get is, whether our sessions involve doing Kegels. So everyone kind of knows Kegels are squeezes. So vaginal squeezes is what it is. Well, yes, that's one of the components, but it's actually a pelvic floor contraction. So it's those muscles actually contracting and squeezing in order to get stronger. Then, are people surprised to know that pelvic floor PTs can also help with pelvic pain? Yeah, definitely. That's probably one of the biggest things. Everyone thinks, okay, Kegels, we're going to get rid of urinary leakage, fecal leakage, just basically for postpartum population only is typically what we'll hear. But it's very common, actually, that there's a lot of people out there suffering from pelvic pain. And that goes from a wide variety of different diagnoses that involves either bladder or bowel symptoms, like constipation can cause pelvic pain, having bladder spasms, so different types of bladder diagnoses can cause that pain. What's the patient population that we see at our clinic? So this is also very surprising for a lot of people. It's about 40% male and 60% female. So in the male population, we see the pelvic pain, especially with prostatitis, so chronic prostatitis, that's a big one. But just from different other types where there's a nerve down in the pelvic floor area called the pudendal nerve, and that can get compressed just from sitting in meetings all day, and also just stress, because not a lot of people know this, but stress goes down into your pelvic floor. What are some common diagnoses that are treated for pain? So Lauren can talk a little bit more about that, just briefly.
Well, you already have a mic.
Nope. Nope, this is my mic. Yep. All right, so we do treat a lot of different diagnoses for pelvic pain. It's a pretty wide array of diagnoses there, being anywhere from right about mid-abdomen down below the hip. So if you experience any pain in this region, it's something that we definitely treat. A lot of patients usually start by going to their doctors, and if this is a chronic pain situation, if they've had this pain for 10, 15 years, they've gone to so many different doctors, and they've just been told, oh, it's in your head. There's nothing there. We've done all the imaging. We can't find what it is. So they come to us, and we're a last-ditch effort for a lot of people. And they say, I don't know what this is. I don't know what pelvic floor physical therapy is, but I'm here because I was told to come here. Don't know what to expect, but let's try it anyway. And so we do a lot of education day one, and we do our exam day one. Our exam typically is going to be an external exam, taking a look at what the muscular tension throughout the pelvic girdle. Oftentimes external tension to those muscles can cause some of that pelvic pain too, but there can be that internal pelvic floor tension as well. If you want to show on the model there. So there are two components to the pelvic floor. There's the superficial pelvic floor muscles, and then there's the deep muscles on the inside here. That's the levator ani. Oftentimes, these muscles can become really clenched up and really tight. The best way to assess the tension there would be either a vaginal or a rectal exam. Now, if a patient does have tension to their pelvic floor muscles, that would be called the pelvic floor dysfunction. And one of the best ways for us to treat would be actually sustaining pressure, trying to relax those muscles. We'll get into the treatments a little bit more a little bit later here too. But let's talk about diagnoses first. So one of the big diagnoses that we see is vestibulodynia. Vestibulodynia means there is a sensitivity or a pain right at the vestibule, which is right at the opening of the vagina. And sensitivity there basically is treated by desensitizing the area. So we would do some soft tissue work just around the entire pelvic girdle. We would do some internal work on all of that. Vaginismus is another diagnosis that we treat pretty frequently. That presents itself as inability to have sexual activity and intercourse, inability to insert tampons. Basically, it just means that the pelvic floor muscles have tensed up so much that nothing can penetrate through. We also treat tailbone pain, bladder pain, urethral pain. Sometimes patients have a hard time differentiating between a urethral pain and a vaginal pain because they feel it when they urinate. And so the best way to really kind of decipher and figure out which one you do have, if you submerge yourself in the tub and then you urinate a little bit, if it's still painful, then it would be a urethral pain. And so kind of just knowing and getting really deep into what the specific pains are, that'll help us so much more with our treatments. We treat pain with sexual activity. We treat transgender surgical pain. After a surgery like that, there's a lot of scar tissue to the area. That scar tissue builds, it adheres, and then that can basically just create a whole light up of pain. So we definitely treat for that too. And then rectal pain can be anal spasms due to muscular tension or constipation. Those are the big ones that we treat.
And then another question that we tend to get a lot too is, or not a lot, another question, but we do refer to other healthcare practitioners. So that is, one of the biggest thing is that it's multidisciplinary. How are we going to get that patient to rehabilitate faster? We need, our team of orthopedic physical therapists who do, just like Therapy Central, to do all the external work and really release all the fascia and work the joints and decompress the nerves. That's a really important part of rehab. Other types of therapies are going to be like psychotherapy. So going to see, obviously with the pelvis being such a vulnerable area of the body, there is that psychological component that can be also psychosomatic. So we need to take a look at that and make sure it's being covered. Sex therapy too, for those couples who have some kind of issue there that needs to be addressed. Any other? Acupuncture is a big one. So I'll talk a little bit about dry needling. That's another thing that me and another therapist at the clinic do, which is actually using the same equipment as acupuncturists, but a completely different method, actually. But acupuncture is great. Seeing a nutritionist, seeing a naturopath. So yeah, dietitian, just having all of the components of trying to have the most holistic approach to treat pain. What can patient expect at their first visit? So Lauren kind of touched on that a little bit. We'll do some external assessments first, muscular-wise, joint-wise, also sometimes neurodynamics. And then we'll go into an internal exam, whether it's vaginal or rectal, depending on where the pain is.
Can I say something?
Yeah.
And really, the most important part of our exam is going to be the subjective, what we're talking with the patient about, finding out exactly how deep that pain goes, how far back it goes. Oftentimes, it can be all traced back to one time in your life. You went through a divorce or you had a child. It was very traumatic. You fell on the ice and you cracked your tailbone. Usually it all comes back to one certain situation and then kind of diving into that and trying to have them rehab the pelvic floor and rehab the surrounding muscles, but then also accepting the situation that also happened in the past.
Yeah, absolutely. That's great that she mentioned that. And what should be worn at a pelvic floor physical therapy session. So that's also really important because it doesn't really matter, actually. For the most part, we'll go over, different types of stretches and other types of exercise, but it's not going to be like in your normal orthopedic setting where there's an open gym and you're having to work out and go on the bike or things like that. We'll do some stretches and things like that within the session in a private room. And then for the internal exam, we have the sheets. Everything is modesty is kept the whole time, everything is covered, and we make sure that we have the consent from the patients at all time. So then moving on to the treatments. So you want to start with manual therapy, the connective tissue manipulation, all the things we do?
Yeah, so manual therapy is basically anything that we do hands-on. We do a lot of myofascial release work, trying to loosen up connective tissues, loosen up the muscles. We do trigger point release, connective tissue manipulation. One thing that people might be surprised to find out is that we do a trigger point release internally as well on those levator ani muscles. And that is honestly one of the most important things that we do that I have found. Basically just holding pressure on that muscle and just waiting for it to completely relax. And you can feel the release, the patient can feel the release. Oftentimes it's a release that they haven't felt for a long time, and so that can be extremely beneficial. So manual therapy is probably what we do the most, and I would say probably for 85-90% of all of our patients we do internal treatments as well. Stretches are a huge portion of what we do as well, but that's something that the patient does on their own. So day one, we educate on stretches. We give them the stretches that they need based on where the muscles are tight. And then we tell them every day, work on your stretches, do them at least once a day. And then depending on how their tissues react, if certain muscles are getting looser, certain ones are still having a harder time, then we would give different stretches after a couple of weeks or so. And we just keep trying different things all the time. Another thing that the patient can do at home is a dilator program. And we have a bunch of dilators over here. They start fairly small and then they work their way up to a larger size. These are going to be really important for women who experience pain with intercourse. Treatments or diagnoses like vaginismus, dyspareunia will be very, very critical for these. Basically, it does what we do in the session, where we do those trigger point releases internally. This is something that the woman can use on herself and basically push into the muscles to get them to relax. There are some dilators that come more like an S shape as well. This is to get certain muscles that are very challenging to get to with straight dilators. Obturator internus muscles in particular are really good for, or are easily attained with
Guys over here.
yes. And so that is another thing that we definitely work on at home. Otherwise, there are anal dilators as well. We didn't bring any of those today, but yes, those are absolutely available as well.
Mm-hmm. And just to kind of add on to the home program in terms of like stretches. So for the most part, it is definitely going to be more about down training, meaning we're really trying to get the muscles to relax as much as possible because probably 80% of the population have more tense pelvic floor muscles than actual weak pelvic floor muscles. However, if you kind of look at like the whole body as a whole image, right, there is going to need, the stability component is really important. So we're looking at like the biomechanics, you know, like how are we creating the muscle balance? Yeah, we need to stretch one part of the body, but then everything around it also needs to stay stabilized. So there's different tools. Do you want to grab the SI belt? Sure. We have a sacroiliac belt, which kind of helps with just kind of stabilizing the SI joint. Typically, a lot of prenatal patients actually will have a lot of SI joint pain, but you'll also see that in people who work at the office and who sit all day and things like that, or even like athletes who are very hypermobile, so they have too much movement, like gymnasts or even yoga teachers or people who practice yoga. Dancers, big time. Yeah, so making sure that we're using some external tools, but also giving them the proper exercises to give that stability component is really important, in addition to stretching. Yeah.
So do you want to explain how to put on the SI belt?
Yeah, so the important thing about the SI belt is you don't want to place it too high above the pelvis where you're kind of up in the lumbar spine, and you don't want to place it too low where you're just kind of at the tailbone or even below the tailbone. So go ahead and turn around if you don't mind. So there's, sometimes people will have like the little dimples over here, which actually is the indication of where the SI joint is. Some people don't have the dimples, but you can most of the time feel it. And so that would be kind of your marker to be able to know where to place it. You just place it right below that little area.
Yeah, and then you would hook it And then you hook it in the middle, and then you want it to go fairly low, right over the pubic symphysis. So then you're completely stabilized all in through here. This is very important for women who are pregnant too, because we give these out quite a bit, and you don't want to put it right over the belly. You want to go right up underneath. But then this one is even better than just regular SI belts because you get a secondary to it as well. So I'll show you about that.
So you can take basically the sides and compress it as you see fit. So that's, the part where wherever you feel like you need the most stability. Because some people may need more stability and actually more compression to that area. Yeah. Good.
And it's worn over shorts. Do you want to talk about how long to wear it?
Yeah, so it's one of those things like when we talk about like braces, we don't want to necessarily give braces for people to depend on for the rest of their lives, because the muscles then at one point are going to start to get inhibited, and then they won't really understand how to function and give that stability that the body needs to do on its own. It's meant to help you and guide you to get to a restored function, but we don't want to depend on it. So typically it'd be only a few months at most. Yeah. I honestly would say weeks, but that's my preference of how I treat. Yeah. And then, so we talked about the dilators. So we mentioned the wand, which is the one that has the curve, and then we have the different size dilators. So the dilators, the hard ones, are for trigger point release. So actually, just like what we would do, we're trying to simulate what we're doing in a session, using the dilator to actually get to the trigger points and to cause that release of the muscle. We have some other ones that are silicone material, so that is more for like muscle relaxation and desensitization, actually. So just inserting it, leaving it there, using some deep breathing. Breathing is so important in pelvic floor therapy.
You should say why.
Yeah, so little piece of education here. So the diaphragm and the pelvic floor really work synergistically. They form the core muscles, and so the diaphragm being at the bottom of the rib cage is a dome-shaped muscle like so, and then the pelvic floor, it goes kind of the other way. So they work very complementary to one another. And when we do our inhalation, the diaphragm actually drops and expands, and then the pelvic floor follows. It also relaxes. On the exhale, everything comes back up. And so there's that component of utilizing your diaphragm and your breath to help relax, but you can also use it on the other hand to help strengthen with the exhalations. So we'll teach that a lot in sessions for the Kegels, yeah. So dry needling, like I was saying, that's one of my big modalities that I like to use. I don't like to be referred as a dry needler because there's no such thing. I'm a physical therapist, and I use dry needling as one of my interventions. So it's commonly used to treat myofascial dysfunction, so really primarily looking at the muscular level. The theory behind it is there's like a combination of two bioelectrical signals that occur at the motor end plate. So this is like physiology, where at the motor end plate of the muscle, those little like muscle cells essentially, they release a neurotransmitter called acetylcholine. When there's excessive amount of acetylcholine, the muscles stay in this contracted state. So what dry needling does is it kind of interrupts that release of the acetylcholine. And we're looking at the two bioelectrical signals being end plate noise and end plate spikes, which is basically spontaneous electrical activity. So with dry needling, physiologically, you have an increase in blood flow, decreases the spontaneous electrical activity. It causes biochemical changes because we're actually changing the mediators like bradykinin and serotonin and some of those interleukins. And then we're also decreasing the banding that's happening at the muscular level. And it can also help to cause changes to the central nervous system.
Can I ask you a question? Oh, go ahead.
Oh, yeah. No, go ahead.
So my question is, when patients ask you the difference between acupuncture and dry needling, what do you say?
Yeah. So really good question. I kind of mentioned it earlier. It's the same types of tools. So let me show you. So we have here the dry needles are what acupuncturists use. Sorry, hold on. Can you hold it for me? Oops. Okay. And just to show you, So the needles are really small. They're really small, little tiny like monofilament needles, very flexible. So the biggest thing is it's not at all acupuncture. Yes, it's the same tool, but you take a doctor or a surgeon and a butcher. They both use the same tools, but it's for completely different intent and method, right? It's the same thing with acupuncture and needling. So here with the needle, we insert it into the muscle, causes an involuntary twitch response, which then accesses a spinal cord reflex and helps to then access the central nervous system and decreases the what we call the nociceptive input into the spinal cord, essentially. So that's the needling part.
What about the stimulation that you use with your needles?
Yeah. So I use 2 different devices. So there's one called Pointer Excel, and then this other one over here, which has different channels. And so if I'm going to be doing different muscles at the same time, it's good to have multiple channels. So a lot of times, going back to kind of where everything originates from, so all the nerves either they're all coming from the spine. And so if I'm assessing the spine, I'm going to put the needles at the level where it's affected, and then I'm going to actually do the peripheral muscle as well. So I'll have the needle at the spine and the needle, let's say, into the QL, and then actually circuit it with the stimulation. Any other questions? That's good. Those are good. People might not think to ask that. And then cupping, so that's all Lauren, because she actually uses that quite a bit.
I do. I do quite a bit of cupping, and a little bit about cupping in general is that it is an ancient Chinese medicine. If you saw the what am I thinking, Olympics a couple years ago, and you saw all those bruises all over the backs of Michael Phelps and everybody else, that's from cupping. So I try not to do the bruising with people just because with regards to the area that we're working on, we don't want bruises everywhere. But the goal behind cupping is that it basically works as a negative pressure. So I would squeeze the cup, and then I would basically put it on the area. Thank you. And then let it go. And it would basically bring the tissue up into the cup, and it acts as a deep tissue massage. So there are 2 different types of cupping. There's the static cupping and there's the running cupping. Those are the 2 main ones that I use, at least. The static cupping is where you pinch, let it go, and hold it there, and that's what produces the bruising. I do the running cupping, and that's basically where you do the same situation, but then you run it up and down the muscle that you want to be working on. So cups come in all sorts of different sizes. There's a teeny little one that I've never used, but usually I use the medium, the large, and then I occasionally will use the extra large too. This is really good for using on the back. I also use some Graston tools as well. These are hard metal solid tools that basically it's like a scraping technique that can help to loosen up the connective tissue. That will loosen up the muscles in turn.
How much of the session do you tend to use those tools?
So what I do when I use those tools is I always start by assessing with my hands. I like to get a good feel for where the muscles are tight, or where the muscles are a little bit tighter, and then figure out how much pressure I need to use, figure out which tool I want to use. And then I would say that with the Graston tool, I only use it until I get the little red dots called the petechiae. That means that you've gotten the blood flow to the area, and then you don't need to do any more, or you could reduce a little bit of tissue damage, more tissue damage. Cupping, basically, because it's just a massage technique, I can do that for as long as I would do the manual therapy.
Perfect. Yeah. Good. All right, and we just have one more thing to go over. Some other tools that we like to use that are really helpful for pelvic floor, the squatty potty. If you guys remember the squatty potty commercial way back when it first came out, it was like this ridiculous commercial with the soft serve and the guy dressed up like a captain or something like that. But anyway, it is a real thing, and what that has to do with is the position of of how we're putting the muscles into. And so it's very mechanically based. And by having the knees up higher than the hips, it allows the pelvic floor muscles to relax. In particular, for people who are suffering from constipation, there's one particular muscle that kind of slings around the rectum. And that one, if it's really tight, can cause a lot of pain when passing a bowel movement. So actually the putting your knees up higher allows that muscle to relax and not squeeze on that rectum as much. Doing bowel massage, so that's one thing. So we actually do quite a bit of visceral manipulation. Viscera just meaning the organs within the abdominal cavity. So we're looking at the colon, we're looking at the bowels. So Lauren can show you kind of how they can do it at home themselves too. But you basically follow from the cecum, go up the ascending colon, across the transverse colon, descending colon to sigmoid, down into the rectum. And so you just follow it. There's a little I love you.
Oh, yes.
Yeah, so I love you is also helpful as a thing to remember. And other little tidbits that we like to teach our patients, like for constipation, drinking warm water in the morning can be helpful. Anything that is warm to the viscera can just help with peristalsis and kind of get things moving. And so we like to kind of have the patients set up a routine, whether that's going for a little walk to the mailbox, drinking their hot water, and trying to pass a bowel movement at the same time every day. Kind of create that cycle and routine. Yeah. That's all we have. So Q&A time. Yeah.
Tons of questions. She might need the mic. Can someone get the mic first? Yeah.
Well, first off, how did a girl with an electrical engineering background get to where you are? I mean, it's like that's, I guess, too long of a story, but fascinating. Pardon me?
It's not that long of a story. I can tell you about it. It's pretty short. So the question was, how did someone like me go from electrical engineering to pelvic floor therapy? So getting into electrical engineering made sense to me at the time. I was really good at physics and math, kind of following in my family's footsteps. My whole family are engineers. And I worked in the industry for about 6 years, and then I realized that I wasn't able to, I knew that in my soul I wanted to make some kind of impact, a more direct impact, and I wasn't getting that from sitting behind a computer all day in a cubicle. So I just figured I love the body and I love fitness and I want to learn more about it. And I discovered orthopedics, and then what was mentioned in my biography, that I had the chance to see the impact that pelvic floor PT really has for patients.
I have one question.
Yeah.
So, as a medical spa, one of the pieces of equipment that some of these laser companies are trying to sell are expensive equipment for, I guess, basically tightening of the vagina is one of the things. And, I've spent way too much money over the years on all this equipment, so, I wasn't even interested. But I'd like you to share, is there any correlation to what they're doing with what you're doing, A? And B, now that I'm in regenerative medicine, what has been introduced also are O shots and P shots. So erectile dysfunction, and then, of course, urinary, just for the female leakage. And so what do you think about those shots as well? So from an equipment position to the O shot and P shot.
From an equipment position, I think it can be a little scary to jump right into a situation like that, especially if you haven't been assessed recently, because it could be that there is weakness to the pelvic floor muscles, but it could be that there's also tension to the pelvic floor muscles. And if you take your muscles that are already tense and then you use that equipment, then you're just tensing up a muscle even more, which can lead to more. And so actually being assessed by a pelvic floor physical therapist or even like an OB-GYN, and actually knowing what's going on first can kind of drive you into the right direction. Sometimes it can be that there is so much tension to the muscles that it's causing that weakness, and that is what can cause the urinary leakage or the fecal leakage as well. So that kind of turns into a two-part treatment for us, where first we would work with just relaxing the muscles, and then we would work on building the strength. Do you want to talk about the O shots and P shots?
Sure. Yeah, so we recently actually really got touched on the subject of O shots and P shots, and I've had maybe a few patients who have had it. I think the trick with that is, from what someone had presented to us, is the figuring out the right potency that's actually being done when they centrifuge it. And so this MD particularly talks about how there's some people who aren't doing the right amplification of it, and it's not actually giving any results. And so you're spending a lot of money, like thousands and thousands of dollars, for something that may not work. That's the extent of what I know, but it's definitely more of a newer thing, I think, that's out there on the market. So.
Are you interested in doing that? Are you interested in adding that or looking at that for your practice?
Yeah, so that would be something that an MD would perform. Right. So it wouldn't be necessarily part of the practice.
But you could just share, refer people.
Yes, we can definitely refer. Absolutely. Yes. Yeah.
So it sounds like the vast majority of people could benefit from pelvic floor therapy, whether they thought they needed it or not. It sounds like it treats all kinds of conditions. As a physical therapy clinic, would an individual wanting to seek treatment with you guys need to get a referral from their primary care physician and then get in with you that way? Like, what's the easiest way to get into Sullivan PT?
So thanks to all the changes that have been done recently, there's direct access now. So you don't have to have a script coming into the clinic. It's only valid for 10 business days, though. So then at that point, you'd have to go back to either a gynecologist or whoever, urologist, your gynecologist, to get a script. Yeah. But anyone can walk into Sullivan Physical Therapy saying, my pelvis hurts, and we can treat you or assess you and treat now.
And treat.
Yeah.
Yes.
Yep, it's the biggest thing.
Can you talk about, I would probably have pelvic pain and not know that I need to go to a pelvic pain physical therapist. So explain what I would be going through to say, hey, you should come here.
Yeah. So we definitely treat a whole wide array of diagnoses. So it could be, if we're talking leakage-wise, could be a urinary leakage, could be a fecal leakage. A lot of people think fecal leakage being like, a lot, but it could just be that little strip on the inside of the underwear. That's still not normal. We treat a lot of postpartum pains and also during pregnancy pains. For pelvic pain in general, if you sit and then feel like there's a pressure kind of building and then it turns into a discomfort just with sitting alone, then that could be a pudendal neuralgia. And then otherwise, pain with intercourse, constipation, those are all big ones that we treat.
Yeah.
Yeah. Did I answer your question?
Just to kind of add on to what she's saying in terms, I think when you're thinking about function, right, she mentioned sitting. So sitting and driving, you're driving 15 minutes and all of a sudden it's too painful or unbearable that you can't do it anymore. That's a big sign that something might be going on in the pelvis. But yeah, you might feel a little bit of pressure, internally down even in the bladder area. You might feel it down. Some patients will actually say, I feel internal vaginal pain. And it could be rectal too. Maybe sometimes there's rectal spasms that happen, probably due to constipation and things like that.
The heaviness sensation?
Heaviness sensation, so prolapse, looking at tissue laxity of, that's going on in the vaginal canal.
I had a couple of questions. Yeah. So, do you treat a lot of cyclists? That's my first question. And the second one, I may have just lost that one. Yeah, I'll think of that later. Man.
Cyclists for sure. That is a big trigger of pudendal neuralgia. Pretty much sitting on that tiny little seat puts a lot of pressure right at the perineum, and that can definitely inflame the pudendal nerve. If you have really intense pudendal nerve entrapment, then it can also cause some bowel bladder dysfunction as well. But yes, cycling is definitely a big one. People that sit for long periods of time just in general will generally have that pelvic pain with the sitting as well. Yeah.
Okay. Prolapse uterus. Is that something that you guys can treat and treat effectively so that condition can be reversed or repaired?
Prolapse, you're asking?
Yes.
You want to talk about it?
Yeah, so he's asking, is prolapse one of the conditions that we can treat? So there's severities of prolapse, and
What is it?
yeah, so prolapse is basically when it typically happens after giving birth to a baby, but essentially the organs kind of fall out of place. So the bladder can actually fall anteriorly or forward in the vaginal canal, or the rectum can also fall back. The uterus can also change position and drop down, where the cervix then gets pulled down a little bit. And what will happen is that heaviness and the bulging that a lot of patients complain about is the actual vaginal tissue that can be sticking out. And so severity-wise, sometimes they'll still feel that heaviness even if you don't see the tissue at the vaginal opening, but you'll still have that heaviness sensation. Most of the time, with the lesser of the severity, we're really able to help manage the symptoms. We're not going to fix the organ placement within the abdominal cavity, but we can certainly help the pelvic floor muscles to strengthen and kind of lift everything up, at least, for the patient to feel less heaviness. And that's the goal.
Or the urinary and bowel symptoms.
Yeah. Yeah. So we're going to wrap it up, and thanks you guys for listening, and